Recording in district commission.
Good evening, everyone. Shall we start the session?
Tessy ma'am has joined. I think we can start with the introduction.
Okay.
Okay. Good evening, everyone. A very warm welcome to the webinar conducted by the Indian Radiological and Imaging Association, Association of Malayalam Movie Artists, and the Swasthi Foundation. This webinar is a series of sessions which were started on October 1st, October being the Breast Cancer Awareness Month, with the opening talk by the senior actress Manju Warrior. This is a curtain raiser program related to the Global Preventive Onco Summit to be held in January 2026. Today is the 18th day of this webinar series, and today's webinar topics for discussion are challenges in physical and emotional healing during chemotherapy, a patient oncologist journey, and why talking about breast health and breast screening is important. So our chief guests for the day are Dr. Tessy Thomas, Vice-Chancellor of Nurul Islam Center for Higher Education and former Director General of Aeronautical Systems Cluster Laboratories and former Project Director for Agni-4 Ballistic Missile in Defense Research and Development Organization, also known as the Missile Woman of India for being the first woman to lead a missile project in this country. She's also the recipient of the Lal Bahadur Shastri National Award and the Dr. Thomas Kangan Leadership Award from FMS IRM Jaipur. We welcome you, ma'am, and are very thankful for joining this session. I request you to speak a few words, ma'am.
Thank you. Very respected organizers, dear doctors and health workers, members from the Indian Radiological and Imaging Association and Preventive Radiology Forum, Association of Malayalam Movie Artists, Swasthi Foundation, our expert speakers, Dr. Ajai, Sasidhar, Dr. Lakshmi J, Dr. T.K. Thomas, anchor Dr. Vidyachandran, special guest Anjali Nair, and all the attendees like students, friends. A very good evening to all of you. I'm truly happy to join you as we are on this month-long effort for breast cancer awareness, prevention, and care. This program is not is more than an event. It is a starting point for thousands of quiet decisions that saves the life. Early detection through self-exams, clinical examinations, and regular mammograms, especially over this 35 years age onwards. A woman coming out for screening, a family learning to watch the early signs, a workplace which makes health checks easy, a community standing with those who are in treatment. And as far as being an aerospace person, every successful mission has three things, that is early sensing, timely decisions, and steady support. And in regarding the breast cancer awareness also, if breast cancer discovered early is far easier to treat, far less costly, and so we need to learn from credible sources. And I'm sure these month-long daily webinars all through this October month are designed for clear guidance from experts. And for prevention, we need to take very small daily choices that, like, maintain a healthy weight and eat a balanced diet rich in fruits, vegetables, whole grains, and no to alcohol, no to smoking. Understand your family history and discuss personalized screening with the doctors. After treatment, also follow the follow up action plan strictly. It's part of prevention against recurrence. So always treatment is always science plus compassion. So cancer care is a teamwork. On one side, radiologists, oncologists, surgeons, nurses, and technologists. But on the other side are our support elements like family, employers, teachers, community leaders, and support groups. Counseling, nutrition, physiotherapy, and peer groups help people finish treatment very strongly. I want to acknowledge IRIA and the Preventive Radiology team for leading with science, AMMA for lending public voice and empathy, Swasthi Foundation for mobilizing communities, our expert speakers for sharing clear guidance, volunteers who run the helplines and logistics, and survivors who are with us tonight. You show us what courage looks like on any ordinary days. When we speak of cancer, many imagine darkness. I see checkpoints like points where a person, a family, and an employer or a community can make a choice that bends towards life, leading towards life. With that spirit, I'm honored to be here with you all on this month long series of daily webinars leading to the Pink Walkathon on October 31st. Let us all learn, screen, support, and stand together for this very noble cause. And Thank you all once again to the organizers for this well-planned curtain raiser for towards the Global Preventive Onco Summit, which is planned in 2026. My best wishes to the speakers and to everyone joining us online and in person. Thank you and wish everybody a good health. Thank you.
Thank you, ma'am. Thank you, ma'am. So true regarding the early detection and how it's not just the medical side, but also the community and the family who come together to fight this cancer. Now, for our senior artist guest for the day is Anjali Nair, a familiar face for all of us. She has made her mark in the film industry, having significant contributions in the Malayalam film and television industry. She was also the recipient of the Kerala State Award for the Best Character Actress for her work in the movie Ben 2015. I welcome you, ma'am, to the session and thank you for joining. I request you to kindly speak a few words. Anjali, ma'am, are you there? Okay, Anjali ma'am has requested 2 minutes. So in between, I would like to welcome Dr. T.K. Thomas, who will be chairing the session. He's professor and head of Department of General Surgery, Sri Gokulam Medical College. Welcome, sir. So the speakers for this, the two speakers for this session are Dr. Ajai Sasidhar, Consultant in Department of Surgical Oncology, NS Memorial Institute of Medical Sciences, Palathara, Kollam. Welcome, sir. And Dr. Lakshmi J, MD, DNB, FRCR, EDIR, who is a Consultant Radiologist in Aster Medicity, Kochi. Welcome, ma'am.
Thank you.
Thank you.
Anjali, ma'am, are you able to speak a few words now?
Hello, can you hear me? Hello.
Yes, ma'am. Yes, ma'am. Welcome, ma'am.
Yeah, hi. So sorry for the small delay.
It's okay, ma'am.
Thank you for the warm welcome. ആൻഡ് ഫസ്റ്റ് ഓഫ് ഓൾ ഒരുപാട് സന്തോഷമുണ്ട്. കാരണം അമ്മയുടെ ഭാഗവത്തായിട്ട് ഇപ്പം നിൽക്കുന്നത് മാത്രമല്ല, അവിടുത്തെ ഒരു എക്സിക്യൂട്ടീവ് കമ്മിറ്റിയിൽ അംഗം എന്ന നിലയിൽ ഇങ്ങനെ ഒരു ഗ്രേറ്റ് മൂവ്മെന്റ് ചെയ്യാൻ സാധിച്ചതിൽ അത് നമ്മൾ നേരിട്ട് അറിഞ്ഞുകൊണ്ടിരിക്കുകയാണ് ആ ഒരു ഫീലിങ്സും. കാരണം 11 ജില്ലകളിലായിട്ട് നമ്മൾ ഓരോരുത്തരെയും ഓരോ അമ്മമാരെയും സഹോദരികളെയൊക്കെ നമ്മൾ വിട്ടുകൊണ്ടിരിക്കുമ്പോൾ അവരുടെ ഭാഗത്തുനിന്ന് കിട്ടുന്ന ആ ഒരു ഫീഡ്ബാക്ക് എന്ന് പറയുന്നത് അത് നമ്മളെ വേറൊരു തലത്തിലേക്കാണ് ആ ഒരു എക്സ്പീരിയൻസ് കൊണ്ടുപോകുന്നത്. അപ്പൊ ഇങ്ങനെ ഒരു വലിയ ഒരു ഗ്ലോബൽ മൂവ്മെന്റിന്റെ ഭാഗമായിട്ട് നിൽക്കാൻ സാധിച്ചതിൽ വളരെ പ്രൗഡ് ഉണ്ട്. ആൻഡ് ഓൾസോ ലൈക്ക് നമ്മുടെ IRI, നമ്മുടെ ഇന്ത്യൻ റേഡിയോളജിക്കൽ ആൻഡ് ഇമേജിംഗ് അസോസിയേഷൻ ആൻഡ് സ്വസ്തി ഫൗണ്ടേഷനും കൂടെ അമ്മയുടെ ഒപ്പം ചേർന്ന് ഇങ്ങനെ ഒരു അവസരം ഒരുക്കി തന്നതിലും ഇന്ന് ഈ സീരീസിൽ എനിക്ക് ഗസ്റ്റ് ആയിട്ട് വരാൻ സാധിച്ചതിലും ഒരുപാട് സന്തോഷം. ഇവിടെ ഒരുപാട് പ്രഗത്ഭരായിട്ടുള്ള ആൾക്കാരുണ്ട്. നമ്മളുടെ ഒരു പ്രസൻസ് ഉണ്ടെങ്കിൽ പോലും അവരുടെ വാക്കുകളാണ് നേരെ എനിക്ക് പോലും ഒരുപാട് ഇൻഫ്ലുവൻസ് ആവുക ഒരുപക്ഷെ അവരുടെ ഭാഗത്തുനിന്ന് കിട്ടുന്ന ഇൻഫർമേഷൻസ് ആയിരിക്കും. കാരണം നമ്മളിപ്പം ഈ ഒരു അസുഖം എന്ന് പറയുന്നത് തന്നെ ഞങ്ങളുടെ ഫ്രണ്ട്സിന്റെ ഇടയിലുള്ള ഫാമിലീസിനും ഒക്കെ ഒരുപാട് പേർക്ക് ഉണ്ടായിട്ടുണ്ട്, എക്സ്പീരിയൻസ്ഡ് ആണ്. പക്ഷെ എങ്കിൽ പോലും നമ്മൾക്കും എങ്ങനെയാണ് പേഴ്സണലി അതിനെ കെയർ ചെയ്യേണ്ടത്, പ്രിവെന്റ് ചെയ്യേണ്ടത് എല്ലാം നമ്മളുടെ ഒരു അറിവനുസരിച്ചിട്ടിരിക്കണം. ഞാനിപ്പം കൂടുതലും ഇതിന്റെ ഒരു ഭാഗമായിട്ട് ഈ ഒരു ഹോസ്പിറ്റലുകളിൽ പോയി തുടങ്ങിയപ്പം അവിടെ ചെയ്യുന്ന കാര്യങ്ങളും അവർ പറഞ്ഞു തരുന്ന ടെസ്റ്റുകളും അതിനോടനുബന്ധിച്ചിട്ട് നമ്മൾ കരുതേണ്ട കാര്യങ്ങളും ഒക്കെ പറയുമ്പം ഇത്രയേറെ ശ്രദ്ധിക്കേണ്ടതായിട്ടുണ്ടോ? ഞാൻ വിചാരിച്ചു എന്തെങ്കിലുമൊക്കെ നമുക്കൊരു വേദന വരുമ്പോ അല്ലെങ്കിൽ ഒരു ബുദ്ധിമുട്ട് വരുമ്പോഴായിരിക്കും നമ്മൾ ഇതൊക്കെ ചെയ്യേണ്ടതെന്നൊക്കെയായിരുന്നു ഞാൻ മനസ്സിലാക്കിയിരുന്നത്. പക്ഷെ എപ്പോഴും ഒരു പ്രിവെൻഷൻ നല്ലതാണ്. ഞാൻ ആദ്യത്തെ ദിവസം പോയപ്പോ തന്നെ ഇതൊരു മാറാ രോഗമല്ല, ഒരു മാറുന്ന രോഗമാണ് എന്നുള്ള വാചകം എന്റെ മനസ്സിൽ കയറി. അതായത് നമ്മൾ നേരത്തെ അറിഞ്ഞിരുന്നു കഴിഞ്ഞാൽ ഇത് വളരെയധികം സുഖപ്രദമാക്കാൻ പറ്റുന്ന ഒരു കാര്യം തന്നെയാണ് എന്ന് അറിഞ്ഞതിൽ വളരെ സന്തോഷമുണ്ട്. അപ്പൊ അതുകൊണ്ട് നമ്മുടെ അമ്മമാര് തന്നെ ഇപ്പൊ നമ്മുടെ വീട്ടിലൊരാളാണെങ്കിൽ പോലും ഞാൻ പോലും നമ്മൾ പിന്നെ ആവട്ടെ നമുക്ക് മറ്റുള്ളവർ സൗകര്യം ഒരുക്കി കൊടുക്കാന്നൊക്കെ പറഞ്ഞ് കുറച്ച് പിൻവലിയുന്ന കൂട്ടത്തിലുള്ളതാണ് ഇപ്പൊ എന്റെ അമ്മയാണെങ്കിലൊക്കെ. അതേപോലെ തന്നെ നമ്മുടെ അമ്മ അസോസിയേഷനിലെ അമ്മമാരും അങ്ങനെ ഒരുപാട് പേരുണ്ടോ, വേണോ വരണോ എന്നൊക്കെ പറഞ്ഞ് ചിന്തിച്ച്, പക്ഷെ നമുക്ക് അവർക്കൊരു അവസരം ഉണ്ടാക്കി കൊടുത്ത് അവരെ വരുത്തിച്ച സമയത്ത് അവര് ഭയങ്കര ബ്ലെസ്ഡ് ഫീലിംഗ് ആയിരുന്നു അവർക്കൊക്കെ നമുക്കിത് ആ സൗകര്യം ചെയ്തു കൊടുത്തപ്പം. അപ്പൊ നമ്മളെല്ലാരും ഒരു കരുതലായിട്ടിരിക്കണം എന്ന് തോന്നിയ നാളുകളാണ് ഇപ്പൊ എന്റെ ജീവിതത്തിൽ കൂടെ പൊയ്ക്കൊണ്ടിരിക്കുന്നത്. അപ്പൊ ഇന്നത്തെ ദിവസം ഇതെല്ലാം നിങ്ങളുടെ ഭാഗത്തു നിന്നുള്ള വാക്കുകൾ കേൾക്കാനാണ് ഞാൻ ആഗ്രഹിക്കുന്നത്. എല്ലാ ഡോക്ടേഴ്സിനും ഇവിടെയുള്ള എല്ലാ അസോസിയേഷൻസിന്റെ ഭാഗവത്തായിട്ട് നിൽക്കുന്ന എല്ലാവർക്കും ഒരു വലിയ നന്ദിയും നമസ്കാരം അറിയിച്ചുകൊണ്ട് ഒരിക്കൽ കൂടെ താങ്ക് യു സോ മച്ച് ഫോർ ദിസ് ടൈം. താങ്ക് യു ദിവ്യ.
Thank you, ma'am. So true. Namala early detection and involving the community in like detecting this cancer is so important. So now we can begin the session. Our first speaker is Dr. Ajai Sasidhar, Consultant in Department of Surgical Oncology, NS Memorial Institute of Medical Sciences, Palathara, Kollam. Over to you, sir.
Hi, my presentation. Is my slides visible?
Yes, sir.
Okay. Thank you, Tessa ma'am, for the kind words. And she actually, I wanted to tell, I think half of them she already spoke. So we know breast cancer, it is the most common cancer which we see in women. So it has its own importance. So if we see the lifetime risk of breast cancer, we can see at least 3 to 4% of all women can have breast cancer in their lifetime. And if you see the spectrum, now previously when we usually tend to see more elder women with breast cancers, mostly about 45, 50, 55 years. But now it has changed. Now we are seeing more young women with breast cancer presenting to the oncology clinics. So as ma'am has already pointed out, each cancer, each individual is different. So each disease is different. Like I always tell to the patient, see, we are all human, but our nature is different. Similarly, even though we group everything under single heading of breast cancer, it affects everyone differently. And also the biology of the cancer is also different in different people. So one group which actually, although comprises less than 10% of whole breast cancer among women, but because of their particular requirement and depending upon their peculiarities, they deserve wider attention. Those group is the younger women. So breast cancer, it is again it is the most common cancer which we see in young women, that is less than 40 years. It represents 5 to 7% of all breast cancer if you see that group. But if you see some studies from India, this group less than 40 years constitute up to 15% of breast cancers. That means if we analyze the population of people coming to our cancer clinics, we tend to see more younger women. And if we see the young age, it by itself, presenting at an young age is an independent adverse prognostic factor, because their further treatment, their chance of like shortening their life because of the breast cancer, these are all more in patients presenting at an younger age. So why the breast cancer is different in young? There are two different reasons. One, if you see, they have more aggressive biology. Like some cancers which are triple negative or HER positive, these are considered high risk type of cancers. They are more common in younger women. And also, younger women tend to have dense breast tissue. So there is always a delay in diagnosis. And also the genetic predisposition, like BRCA mutations, P53 mutations, all these are more in younger women. And the chance of having a second malignancy because of the genetic predisposition are also more in younger women. And this 40 years of age, or 35 to 40 or 50 years of age, this is also a crucial period in our life. By career-wise also, they are at the peak of their career. And in the family-wise, they probably act as an anchor holding everything together. So if they are affected by especially a disease which carries so much stigma like breast cancer, that again carries higher psychosocial burden. And why there is a delay? I already told you, because there is always a delay in diagnosis of breast cancer in young patients. Why there is a delay? Because if you see the probability of malignancy when a patient presents with a breast lump, we all know that breast lump is the most common presentation which we see in our OPD. When patients present with a breast lump, that is the most common type, like most common way the patients comes to us. So if there is a simple lump in the breast, the chance of malignancy in the lump varies according to the age. So less than 20 years, there is only 0 to 1.5% chance of malignancy of the lump being turned, like a lump being actually malignant. In 20 to 30 years, the chance is about 5%. And it grows according to the age. By 31 to 40%, 30% of new onset breast lumps could be malignant. And the same risk goes up as the age increases. So if we see together, like if some patient presents with a breast lump, if they are less than 40 years of age, the chance of malignancy maximum, like it's very less now. Like it is actually less than 10% only. So most of the doctors also tend to ignore the finding, thinking that this could be a non-malignant issue, or an issue which goes due to the changes in the development of the breast, like a fibroadenoma. So the clinical suspicion itself is very less. So those patients tend to get evaluated less, and so their chance of detecting a malignancy is also less. And this, along with combined with dense breast tissue, which reduces the sensitivity of mammography or ultrasound, along with our own notion that this could not be a malignant lesion because of the chance of being malignancy is very less. And this leads to an advanced stage at presentation when a young woman presents with breast cancer. So at every stage, the diagnosis itself is challenging because of the dense breast tissue, and the further treatment also is different. If the patient presents with an early breast cancer, the treatment usually is surgical. First will be surgery, followed by adjuvant therapy, like chemotherapy or radiation will be required depending upon the pathological report of the initial surgery. So surgical challenges, there are certain challenges which we face while dealing with a young patient. See, we during this webinar, many already might have pointed out that breast cancer, the development of cancer in the breast does not mean that the whole of the breast needs to be removed. There are certain techniques which can be used to conserve the breast and to reduce the probable adverse cosmetic outcome. We all know that removing a breast carries not only cosmetic, psychological, as well as difficulties in all the domains a woman goes to with. So how to reduce the psychological or psychosocial problems associated with the loss of breast? So there are certain techniques which can be adopted for balancing oncological safety with cosmesis. So our primary aim of the treatment is oncological safety. That means the cancer should not come back. That is the primary aim. So many of the cases will require wider margins. So taking wider margin along with the lump means there will be volume loss will be there. So if you don't do anything, the cosmetic outcome will be very bad. There will be change of the nipple position. There will be volume loss leading to puckering of the skin, and size will be different. So all those problems will happen if we only remove the lump. So there are certain techniques where we utilize the techniques of plastic surgery along with cancer care. So this technique is called oncoplastic surgery. That means plastic surgery and cancer removal are combined together in the same sitting. So during the surgery itself, some kind of cosmetic procedure is also done so that the breast will retain its shape. So there, depending upon the presentation and depending upon the location of the tumor, there could be different types of techniques which can be adopted. So we can conserve the breast. So the one thing which I wanted to stress is breast cancer does not mean removal of the whole breast. It is not required. The breast conservation surgery or lumpectomy plus axillary staging, this is called a breast conservation surgery. So breast conservation surgery is also oncologically safe. If we compare the outcome of breast conservation surgery with mastectomy, if we keep the patient for longer follow-up, there are certain studies which have shown that oncoplastic breast surgery or the breast conservation surgery carries better outcome, better oncological outcome. The cancer tends to come back less, contrary to our belief in breast conservation surgery. And also we can provide reconstruction in the same sitting. Always immediate breast reconstruction is preferred so that the patient need to undergo the stress for surgery only once. So even many patients can be treated with oncoplastic surgery, but there will be a certain group of patients with the multiple cancers in multiple quadrants of the breast, or some patients will be there for whom the breast conservation surgery may not be adequate. For those patients will require a mastectomy or removal of the whole breast tissue. Again, removal of the whole breast tissue does not mean, again, removal of the whole breast. We can keep the skin envelope, we can keep the nipple, and the volume lost can be reconstituted by muscle like the latissimus dorsi muscle from the back or from the fat of the abdomen, like the tram flap. Those tissue can be repositioned towards the breast so that we can provide a better outcome. Actually, I have photos, but there is certain nowadays people discourage sharing photos in the social platform. So that's why I'm not putting photos. So these are the representative images which I have shown. Depending upon the location of the tumor, oncoplasty techniques can be used. And if breast conservation is still not possible, again, breast may be preserved by techniques like LD, latissimus dorsi flap, or tram flap. And those people, the younger people have usually have a higher genetic risk. So some people like a BRCA mutation carrier might require prophylactic mastectomy. So that also has to be discussed with the patient. And one more important thing in young patients especially is the fertility preservation. So we know that surgery by itself does not cause any difficulty in pregnancy, in future pregnancy, but we all know that the systemic therapy or the chemotherapy that always has a component which potential to reduce the future fertility and can interfere with the future fertility. So these are some unique challenges, surgical challenges, which we face. And this can be managed by well-planned approaches also. Like we can adopt oncology surgery, we can provide reconstruction, and we can manage the genetic risk accordingly with maybe some people will require prophylactic mastectomy, or some people, if they have a high-risk mutation, we can screen the other breast with MRI and keep the patient under follow-up. And fertility preservation, again, so many options are there, which we will discuss. And the next question which we get is, should they require chemotherapy? So that is the most important question which I usually face. So if you see the younger patients, see, most of the people will have aggressive histology, like I already told, triple negative or HAR positive. And if you see, they are expected to have a longer lifespan also. So the possibility of the patient requiring chemotherapy is actually very high. There are many considerations like to tailor the patient. See, initial part of the treatment, when we started the breast cancer treatment, maybe 50 years back, everybody used to follow the same kind of treatment, surgery followed by chemotherapy and some people radiation like that. But now the scenario has changed. We see the biology of the tumor. We see how the tumor might behave according to its molecular characteristics. And the treatment is tailored for the individual client or individual patient. But if you see the younger patients, most of the people will require intensive chemotherapy. So intensive chemotherapy will again comes with its own problems. First, the impact on fertility, because there will be ovarian suppression will be there. And some drugs can have cardiotoxicity, like anti-HER therapy, like Herceptin, can have cardiotoxicity. And these things will compound when we see their lifespan. See, the young patients, they tend to live longer because of the effective chemotherapy and treatment options are available. And because of their life, their post-surgery or post-therapy life is more, their problems can potentiate in slowly during the time. And one more important thing is hair loss. We cannot prevent hair loss in a reliable way, actually. But there are certain new techniques available like scalp cooling, which can be used to prevent up to maybe it is effective up to 30 to 50% of the cases. And again, systemic chemotherapy is actually required. Why systemic chemotherapy? Again, the question comes. See, the surgery and radiation, that usually addresses one phase of the disease. Whatever in the local region, we can remove only that. The lump which is seen, that is removed by surgery. And the remaining microscopic disease can be treated with radiotherapy. But when the disease is 1 centimeter, it has the potential to go through the bloodstream to different organs. They are the seeds which can grow in different organs. So to prevent that, to prevent a secondary being developed, what we should do? We should be giving chemotherapy to the blood because the cells are circulating through the blood. So chemotherapy or the drugs has to be given through the blood. So that has to be done by systemic therapy. So systemic therapy may be systemic chemotherapy, and newer drugs like immunotherapy and targeted therapy, all are there, either injections or by tablets. Again, this addresses the second phase of the disease, that is the systemic or the cells which are already circulating at the time of diagnosis itself, which is going through and seeking a fertile soil to grow. So systemic therapy mostly will be required for the for young patients. And again, psychosocial challenges, the psychosocial burden of diagnosis of breast cancer in young is very huge. The shock of diagnosis at any young age, again, at their most productive age of 35 or 40, they are having the shock of breast cancer. And again, body image at the peak of their sexual life and intimacy issues also will be there. And again, the treatment for cancer is costly now. So the drugs are costly. the newer therapy means there is prolonged surgery will be there. So again, surgical cost will be very high, and patient will also have family planning concerns. So these are all are peculiar for people with diagnosed breast cancer at a young age. And chemo-induced fertility risk is there, at least some 30%. Like if we follow the patients in the reproductive age post chemotherapy, usually 50 to 75% of the people will regain their ovarian function, and some 10 to 25% of the patient will lose, especially towards the later ages, like 45, like 40 or 45, they might lose the ovarian function, and some kind of toxicity will always be there for the ovum while chemotherapy. So there are certain options like oocyte or embryo cryopreservation can be used. That is, before starting of chemotherapy, the ovum can be preserved or the embryo can be preserved, so that post therapy that can be used as a IVF like kind of thing for fertility. And another question is timing of pregnancy after treatment. Usually, if you see 6 to 12 months post therapy, the patient can become pregnant. But ideally, it's always prudent to wait for at least 2 years, because after treatment, the chance of recurrence also is there. The chance of recurrence is very high in the initial 2 years of treatment. So it's always prudent to delay the pregnancy after 2 years, but after 6 months to 1 year also, pregnancy may be tried. And again, there are post-surgery, there may be hormonal drugs. So it can cause early menopause. The risk of osteoporosis is there. Sexual dysfunction is there. And for young patients with the BRCA mutations, the risk of second cancers is also there, like in ovary, it is there. And again, the fear of recurrence and need of lifelong surveillance is also there. So we always tell, for an oncologist, the patient means she has to follow up till either the oncologist or the patient completes their life, because lifelong follow-up is required actually. And also the intense follow-up is required in the initial period. Probably 3 monthly for the first 2 years, and 6 monthly for the first 5 years, the next 3 years, and then at least yearly for till the patient maintains their healthy life. Till that much follow-up is actually required. And again, the social and cultural issues, stigma regarding marriage and fertility is actually very high. See, like most of the people will tell, like, don't tell our, the closed group, don't tell anybody outside our closed group, because the stigma regarding breast cancer is still there. Because people still consider breast cancer or a cancer as a problem which has, like, there is some problem with me, that's why some issue is there, that's why I got that. We tend to blame ourselves. But actually, that is not we actually don't know why the patient developed. Maybe there will be some genetic and environmental issues, but ultimately it's not our fault that we got the disease. So, but still the people carry the stigma, and they want to keep it very like to themselves like that. Again, stigma regarding marriage or fertility is also there, especially for young patients. And most important thing which we are trying to address is the lack of awareness in community. Like initially, Anjali Madam also told, she came to know that breast cancer is curable. It is not a full stop to the life, that she understood through this webinar. So that's a powerful message that I again ask the patient, the patient sometimes if they like breaks new tear in our OP when we open the diagnosis. We don't cry when we get the diagnosis of fever, because we all know that it can be cured completely, and you will resume whatever duties and whatever job or whatever you are doing now after a short period, short interval, and you will be able to carry on with your life. But in the same thing is there with the cancer also. You can continue whatever life you are having now, even after, but you have to diligently follow the treatment options and the diagnosis and the treatment options. So they can have a normal, fulfilling life even after the diagnosis and treatment of cancer. And again, the limited support system is there. If you see the Western world, their cancer support groups are there. It provides an avenue for people to vent out their feelings and get support from the similarly minded people. That support system is more prudent in Western countries, but that is completely lacking. Even in Kerala, which we boast of high literacy rate and everything, but we still does not have in support systems. But these initiatives while providing awareness and while highlighting these unique problems in these marginalized, maybe because these people are very small now in that. So these people, while highlighting that, probably in the future, we will be able to provide better support systems. And again, the most important thing in the breast cancer care is the multidisciplinary care. See, the problems which people face during their diagnosis and treatment is multifaceted. There are so many different problems are there. So one care provider cannot give care. We cannot address everything. Surgeon can treat the disease with surgery. One radiation therapist can be giving radiotherapy and everything. But still, only one person cannot cater to all the needs of the patient. So it's always a teamwork. It includes surgeon, radiation oncologist, medical oncologist, pathologist, and social worker, genetic counselor, physical therapy, radiation. So it's a big team. It is actually required, and everybody is working towards a patient and centered treatment planning. And we also require survivorship clinics and support groups so that the continuous care and the continuous psychological support can be provided to the patients. So coming to the summary, so the survival is improving with modern therapies and breast cancer is curable. And since the survival is improving, the younger patients have their own issues. But many of the things can be managed with the modern surgical, medical, and therapies in a multidisciplinary care. Surgery can be adopted and breast may not be removed. Yes. And even though, and there are certain options like oncoplastic breast surgeries are there, which provides better cosmesis and which provides better quality of life. And if for the patients concerned with fertility, fertility preservation may be done, and so that motherhood is possible after cancer. And we need to provide strong support networks, and we should work towards reducing stigma. So there are unique challenges are there. Treat not just the disease, but the patient's future. That is the take-home message which I need to give. Thank you.
Thank you, sir. I'll open up the session for any questions. You can either ask or put it in the chat. Thank you, sir, for highlighting not just the medical, but also the other sides of cancer treatment, like the psychological burden that it takes on the patient and the social stigma associated with it, and what we as a community can do to better that. Sir, I would like to ask a doubt. You told that in younger patients, this cancer is much more aggressive. So what can we do to screen younger patients so that it can be detected earlier? Who should undergo screening from a younger age?
See, if you see, there are certain risk categorization is there for breast cancer. The risk depending upon our family history. There are two different kinds of breast cancer. One is familial breast cancer that happens in a patient with a very strong family history. There may be multiple first and second line relatives with the breast cancer. So they comes to the high risk group. And the rest of the people, like normal, they carry only the population risk. That means population risk is we are living in a population. So the population inherently, because of our habit, because of our environmental exposure, we have a certain risk. So that is a population risk. So that is about, in Kerala, it is about, we diagnose about 50 new breast cancer per 1 lakh women. So that is the normal risk. So a certain group, like more than one first degree relatives, or 2 or 3 second degree relatives, and generations of family are affected. These kind of people comes in a high risk group. And again, there are online risk categorization algorithms are available. So that can also be used. But depending upon that, if we come in a high risk group, so those people has to be like, they should undergo genetic screening. So genetic screening, actually, it's a panel of tests, which usually consists of BRCA1, BRCA2, P53 mutations. So whatever common in this population, that usually they will screen during the testing. And if they fall to that group, that is genetic risk cancer is there, or they have a high familial risk, again, multiple family histories there, those people should undergo a screening from at least 25 years of age. Those people will require multiple screening. So mammography may not be very sensitive to them because the breast tissue is very dense. So if you fall under high risk group, maybe sometimes MR mammography may be required. So basically, we have to characterize our own risk depending upon our family history, whether we fall in a high risk group or in a low risk group. So if you are in a high risk group with multiple family history, then they should start at least 10 years before the earliest people. Like in the family, somebody diagnosed with 35 at the age of 35, then we should start screening at least 10 years early for the youngest members of the family. Like 10 to 35 means is it at least 25 years like that. Because as the family progresses through generations, the cancer tend to appear even younger. Like in 35, then their children might get at 33. Like that, there is a possibilities there. So they have to start 10 years early. So these are different actual risk groups. One is population risk, one is genetic as well as familial risk. That is only 10% of the normal breast cancers. 90% of them will have only population risk. That is about 50 per 1 lakh per year.
Thank you, sir. Any doubts, you can enter in the chat. Now, I would like to invite our next speaker, Dr. Lakshmi J, MD, DNB, FRCR, EDIR, Consultant Radiologist in Aster Medicity, Kochi. Welcome, ma'am. Over to you.
Is my screen visible?
Yes, ma'am, it's visible.
Okay, so good evening, everybody. I'm very glad to be here talking about the importance of breast screening. So as a population, we need to have more awareness about breast cancer screening because as reinforced by everybody, it is the most common cancer in women in the world and second most common leading cause of cancer deaths in women. And in India, almost 60% of the women present at an advanced stage and almost 1 in 8 women are diagnosed with breast cancer in their lifetime. So, and there are a lot of myths around breast cancer in the population, which needs to be tackled with facts. And breast cancer is something when detected at an early stage, there is almost 100% cure and the survival rate is much, much higher when in contrast to when detected at a later stage. And breast cancer is special in this case because none of the other organ cancers have such a good survival rate when detected early. And there needs to be an awareness regarding how breast cancer presents, like how it presents. It can present as a lump, it can present as nipple discharge or change in shape of the breast, all that. And we also need to be aware of the risk factors that can cause breast cancer, like just being older than 40 is in itself is a risk factor, and family history definitely is a risk factor, and having denser breast tissue like we Indians have is a kind of a risk factor. So we need to be aware how it presents. So when the cancer presents as a lump, that is when the patient comes to the doctor saying that there's a lump. But breast cancer is special, wherein we have an imaging modality which can detect cancer even before one can see it or one can feel it. And that is what is called as screening. So in screening, it is checking for cancer in people who do not have any signs or symptoms. So in that case, we detect cancer at a very early stage when it is very small, and thereby improving the treatment outcome in such patients. So screening can be done with different radiological methods, can be mammography, ultrasound, breast MRI, or just with self-breast examination or clinical breast examination by the doctor. But the best screening modality is mammogram. It is mammogram, and especially for women above 40 years of age. Mammogram is best because it is the only proven modality which has shown reduction in mortality. That means it has shown reduction in deaths due to breast cancer because it detects cancers much, much earlier than we can see or feel clinically. In India, we have opportunistic screening. So unlike Western countries where there are very systematic population-based government-sponsored screening methods, India does not have such a systematic screening. So we follow opportunistic screening. So if a patient comes to the doctor or sometimes mostly to the gynecologist for any other symptom like stomach pain or bleeding issues, the doctor then sees that the patient is above 40 years old and she has not done a mammogram yet, and she refers the patient for a mammogram. Or the patient herself is aware that after 40 years of age, we have to get screened screened for breast cancer detection. So that is called opportunistic screening. So for that to happen, the population needs to be aware that such a thing is there, such a mammogram can detect cancers early. Okay, so breast cancer detection, when done early, there is definitely improved prognosis, that is improved outcome, less invasive treatment. So suppose we detect cancer, which is very small, 4 millimeter in size, you can conserve the breast tissue. As Dr. Ajay just said, there are methods to conserve the breast tissue, removing only the cancer tissue and normal tissue around it, instead of going for total breast removal or extensive axillary lymph node. That is when the disease has spread to the armpit, you need to address the lymph nodes also. So all that can be avoided when the cancer is detected much earlier. Then there is preservation of breast tissue, the quality of life improves, and definitely the long-term survival is improved. So barriers to screening is usually fear of mammography, uncertain about how it is going to be, is the radiation associated with it. All that is fear and anxiety, and lack of awareness definitely hinders people from coming forward to screen. So there are a lot of myths around breast cancer. One of the most common questions that patients ask when we tell them to come next year for the next screening mammogram, they said, do we require annual screening mammogram? Does it involve radiation? Can it itself cause cancer? So the answer is a definite no. Actually, the background radiation in the place we live, especially in Kerala, the background radiation is much more than what a mammogram exposes us to. So the radiation dose is very low and it is not going to cause cancer. And the benefits of getting a mammogram done is much outweighs the risks. Definitely, there is a small amount of radiation, but it is negligible. And women with small breasts do not get breast cancer. That is a myth. So it doesn't depend on the size. Dense breast tissue and anybody can get breast cancer. And people with family history are not the only ones that get breast cancer. They definitely have a higher risk of getting breast cancer, but most of the women detected with breast cancer do not have any family history. So many are very surprised when we say that they have a cancer. They said nobody in our family has cancer. How did I get? So it is unrelated to family history. Family history does increase the risk, but it can come independent of it also. So people need not be worried of every mass that comes. So people can get lumps like cysts or fibroadenomas. Those are all hormone-related changes. But we can never know just by touching or feeling. It is always better to get it imaged or scanned. There are other myths like only older women can get breast cancer. Dr. Ajay just explained very clearly that the age of onset is decreasing, especially in urban population. So when do we do a screening breast mammogram? It starts at the age of 40 because studies say that there is a difference in mortality. This is mortality after the age of 40. So studies say we start at 40 and before that the breast is very dense. And in that case, mammogram might not be that efficient because smaller masses can be masked by the dense breast. So after 40, every year till the age of 70, and if there is something detected on mammogram, we might suggest a follow-up, and the patients just have to follow whatever we are writing according to a category that we give, PIRATS category. And whenever we do a screening mammogram, that is, patient does not have any symptom, it is always ideal to schedule it during the first 2 weeks of her periods. Like between the 7 to 10 days is the most ideal time when the breast is very soft, or there's no fluid in the breast. Lesions are better seen during that time. So when the patient has a lump, she does not have to wait for her next cycle. This I'm talking only about screening mammogram. When you are scheduling a mammogram, it is better to do it in the first 2 weeks of your period, but especially 7 to 10 days. I'll just show you an example. This is just a mammogram of a patient who came for a screening mammogram. She was not willing. She had a sister who was diagnosed with cancer, treated. She insisted that her sister gets a mammogram done. She pushed the patient to get a screening mammogram done as a part of wellness checkup. And there was a small 4 millimeter, this white thing that we see, very small 4 millimeter mass that was picked up. It was not felt at all. And this patient will undergo direct breast conservation surgery. Just this small cancer and some tissue around it will be removed, and her outcome will be very good. In contrast to a patient who presented with a lump, for a lady who presented with a big mass in the breast, on mammogram, we actually saw multiple masses, at least 2 masses, along with all skin changes, lump in the armpit. So this was already spread to different parts of the body, and that is when the patient could feel the lump and come to the doctor. And treatment becomes extensive for this patient. So what I'm trying to say is, let's normalize breast conservation conversations. So recently there's a lot of buzz about women over 40 doing weight training, increasing protein intake, and really pumped about fitness. And which is rightly so, which should happen. But real fitness also includes taking care of our health. And mammogram is something that can be easily incorporated into our fitness routine. We just have to do it once a year to detect cancer at a much, much earlier stage than when it presents as a lump. So let's just encourage, let's just push, motivate, sponsor, or whatever it takes to get our near and dear. First, we have to take care of ourselves. We have to volunteer for a screening mammogram after age of 40 and push near and dear ones to get it done. So find it early and fight it early should be the motto. And in age less than 40, as Sir said, mammogram is not used as a primary screening technique. Only if the patient has a high risk of cancer, MRI can be done, and ultrasound can be done as a complementary study to MRI. But usually in less than 40, patients come for ultrasound when there is a lump or something. Thank you.
Thank you, ma'am. Thank you, ma'am, for highlighting the importance of mammography, because we have such a amazing investigation which will detect it way earlier than any symptoms arise, and that significantly reduces the mortality and the risk. Thank you, ma'am. If there is any doubts, you can either ask or put it in the chat. I guess there are no doubts then. Now the time has approached, so let's wrap up this session. I would like to thank our chief guests, Anjali Nair and Tessy Thomas, for gracing this occasion.
Divya. Thank you so much.
Thank you. And I'd also like to thank Dr. T.K. Thomas for chairing the session, and our 2 wonderful speakers, Dr. Ajai Sasidhar and Dr. Lakshmi J. Thank you everyone for joining the session, and hope you have a good night.
Thank you. Thank you, everyone. Good night.
Thank you.
Yeah.
Thank you.
Thank you.